My name is Doris Hansen from Moffitt Cancer Center. So today I'll be presenting on comparison of time to next treatment or death between frontline Daratumumab, Lenalidomide, Dexamethasone, or DRD, and Bortezomib, Lenalidomide, Dexamethasone, or BRD, in transplant-ineligible patients with newly diagnosed multiple myeloma. So commonly clinical guidelines for patients with newly diagnosed multiple myeloma consider the use of induction chemotherapy followed by high-dose chemotherapy, such as Moffitt, followed by autologous stem cell transplantation. However, if somebody is older and they're more frail, transplant may not be an option. So generally, the two preferred regimens in the National Comprehensive Care Network guidelines are DRD and VRD as frontline regimens for transplant-ineligible patients. There have been no head-to-head randomized clinical trials, but there's been some other comparative analysis. The objective of our study was to compare the time to next treatment or death between frontline use of DRD versus VRD in transplant-ineligible patients with multiple myeloma, but also to add to the possible evidence base regarding comparative effectiveness between these two regimens. So the time to next treatment is a well-established measure, and it was chosen for this study because there is a lack of data on progression in these retrospective databases. So the database that we used for this study was the Essentials database, which is a de-identified electronic medical record. We essentially identified patients treated between January 1, 2018 to May 31st, 2023. And we used a type of statistical analysis known as the inverse probability of treatment weighting to essentially adjust baseline characteristics between patients. We identified that 643 patients were eligible for this study. 149 received DRD and 494 received BRD. And as I mentioned, we used inverse probability of treatment weighting to adjust baseline characteristics. After this adjustment, our patient characteristics were fairly similar. We identified mean age to be 75. Contrast and comorbidity index was similar. There was some minor imbalances between the groups, but these were adjusted again using a doubly robust Cox regression model. In terms of, what are the main results of the study? So the main results of the study is that DRD was associated with a longer time to next treatment or death compared to VRD. In particular, 32% of patients receiving DRD as opposed to 51% had advanced or subsequent therapy or died. It's important to note that DRD was associated with a 42% lower risk of disease or progression to a subsequent therapy or dying, as evidenced by an adjusted hazard ratio of 0.58. And also, in this study, we showed that the median time to next treatment or death was approximately 38 months for patients receiving DRD and approximately 19 months for patients receiving VRD. Certainly, like any retrospective analysis using a database, the study has limitations. Particularly, there may be administrative censoring, or right bias. If patient went out of network, we may have missed some information, or the Essentials database had some misinformation regarding ECOG performance status or variables required for frailty calculation or cytogenetics. And I think it's important to also note that time to next treatment is not a direct proxy for progression-free survival because it can be impacted by physician and patient decisions regarding starting a subsequent therapy, which may not be related to progression by IMWG response criteria. So in conclusion, our study did show that frontline DRD was associated with a longer time to next treatment or death, as evidenced by a 42% risk reduction. Our study does support the use of DRD over VRD, similar to the other studies like the Doris, the chart review, as well as other adjusted and direct comparisons like Pegasus. And hopefully, in the absence of head-to-head randomized clinical trials, our study does support the clinical effectiveness of DRD and hopefully will assist clinicians in informed decision-making for choosing frontline therapy for patients with transplant-ineligible multiple myeloma. Thank you very much.